Were you and your co-authors anticipating any particular findings when you set out to study medication adherence and outcomes among patients who had been discharged from the hospital following myocardial infarction? If so, were the results in line with your expectations?
So we were evaluating whether the eliminating copayments for evidence-based medications would improve adherence and improve rates of clinical outcomes for high-risk patients who've been discharged from hospital after a heart attack. And so we were testing a hypothesis that has been advocated for the past decade or so, that this strategy would improve quality and potentially also reduce cost. And economic models that we had generated prior to the start of this trial supported the idea that that may be true. So we certainly had the hypothesis that adherence would go up and that the changes in adherence would be large enough to result in clinically meaningful events. That's what we ended up seeing. We were a little surprised in a way by the relatively modest magnitude of the size of adherence improvement that we saw. So we saw adherence improvements of 4 to 6 percentage points for each of the 3 medication classes that we studied, which were ACE inhibitors and angiotensin receptor blockers, statins, and beta blockers. And this is very much in line with all the observational data that exists about the benefits seen from value-based insurance design programs. But we thought, in principle, we might see larger improvements than that. Despite that relatively small improvements in adherence that we did observe, there were significant reductions in major vascular events. And as a consequence, it sort of makes the case that even modest improvements in adherence in this high-risk patient population may be enough to result in clinically meaningful results.